webinar of the Connecticut Health Policy Project on Health Information Exchange and Patient Privacy Consent. I'm Ellen Andrews, Executive Director of the project. We are fortunate to have Ted Kramer and Steve Allen with us from two of New York's health information exchanges. All of Connecticut's neighboring states, including New York, have adopted opt-in privacy policies, meaning that patients must consent before their records are shared on the exchange. Connecticut policymakers are now considering how to operate health information exchanges and developing privacy policies for our states. Lots of questions have been raised about how an opt-in policy would work and what our neighboring states' experiences have been in collecting those patient consents. So we're very lucky to have Ted and Steve with us. Ted joined the Rochester RIO in 2006 and has led the organization from its inception. He has worked in the health information field since 1985 in such areas as managed care, clinical trial systems, and consumer-directed health offerings. Active in New York State policy formation, he has served as co-chair of the New York eHealth Collaborative's Technical Work Group and co-chair of the Privacy Work Group. He received his undergraduate degree from the University of California, Santa Barbara, and his master's degree in public health from here at Yale, just down the street. He serves on the board of Fort Research Systems, a provider of clinical trial software solutions, and is a member of the Monroe County Board of Health. Steve is director of the Western New York Health E-Link, the Western New York Clinical Information Exchange. It's a nonprofit organization established to develop a privacy-protected, community-based system for healthcare providers and consumers to electronically share important medical and clinical information more efficiently. Health E-Link is a collaborative consortium that currently includes the Catholic Health System, the Erie County Medical Center Corporation, Blue Cross Blue Shield of Western New York, Independent Health Association, Kaleida Health, Roswell Park Cancer Institute, and Univera Healthcare. Health E-Link has the ability to serve healthcare providers throughout the 8 counties of Western New York, and Health E-Link was created through a $3.5 million grant from New York State's Heal New York initiative. Some housekeeping for the webinar. If you're listening on the phone, remember to input the audio pin that should be visible on your screen if you want to be able to talk and ask questions. We will be keeping everyone on mute until the speakers are finished, and then we'll have some time for questions. To ask a question, you can raise your hand by clicking on the Raise Your Hand button, or you can type your questions into the question pane text box on your screen at any point in the webinar. A video of this webinar will be posted online soon. So we'll start with Ted.
Well, thanks very much. And so Steve and I are going to kind of be walking through these slides a little together in an effort to sort of share our efforts. We're sort of partnering up here. So I'm going to walk through a slide and then see if Steve's got some insights from the Buffalo experience as well. And I think I have control of the slides now. Do I?
You should, yes.
Let's see. Not so much yet. Still waiting to see if it works for us here. Ellen, I might have to have you page forward. It's not letting me move forward here. Hold on, let me try one other thing. This is technology. This is what we do. Okay, so on our regional services, just as a little background, we have 2 core service offerings, both a what we call a results delivery model that does not require consent, and a patient-centric query portal that some 400 organizations use that does require consent. So it's always important to realize that not all HIE services actually need consent at the outset. And as we look at EHR interoperability, more of this one-to-one exchange will expand over time with patient summaries, and we're looking at EHRs actually being able to initiate patient queries, but those would require consent.
So from our perspective in Buffalo, interestingly enough, both Rochester and Buffalo use the same core technology to drive the exchanges. We happen to use axolotl. Our services are the same. Our numbers are a little different. We currently have about 50 practices who are getting the one-to-one results delivery. We have about 250 organizations, practices basically, that are able to use the portal for query purposes. We do have the interoperability up with about 40 practices currently that is part of referral exchanges, again still one-to-one, but what's unique about that is the ability for a practice that may have MedEnt as their EMR vendor package up a CCD clinical summary and send it through the exchange to another practice using eClinicalWorks, for instance, and have that data downloaded as discrete data into the patient's chart in eClinicalWorks. So the idea of EMR to EMR exchange, we're in the process of building up. And we have about 40 practices currently engaged in that service.
All right. So on the privacy background, this is a place where I think Buffalo and Rochester both were engaged at a state level. There were statewide HISPIC contracts, which are sort of federal contracts to look at privacy. The first one across the state was to really sort of inventory how people saw HIPAA and how they were operationalizing it. There was a second state contract where we were charged with coming up with a statewide consent process. Locally, we worked with 15 of our regional hospitals as well and convened a privacy work group and really did some early outreach to consumers to sort of see what their concerns were around privacy and consent. All of these things helped us define our initial approach with an opt-in per practice or covered entity. It's sort of the New York State approach. And we're using now a New York State consent form. Steve, to you?
Yeah. So that's correct. I mean, the process and our engagement has been pretty much the same. We do have locally, as I think Ted might have mentioned for Rochester, we've got a local privacy committee and a separate security committee that meets on a fairly regular basis to review, where we are relative to local policy above and beyond what New York and other entities, what the constraints that they place on us. So it's a pretty active dialogue and ongoing for sure.
So moving forward, when we look at sort of the regional principles that we've endorsed, we always try and keep things really simple. Patient engagement and communications was really key to our consent approach. We have had a lot of regional outreach that we'll talk through. We've really tried to include as many patients as possible, both behavioral health, mental health patients. We're working on supporting the SAMHSA requirements that are slowly getting enunciated, and we've worked on trying to keep minors through a minor pilot. There's some interesting issues with minor consent that are sort of baked into both New York, some of the New York regs. And I think somewhat unique for us early on is we had a very broad focus on a continuum of care where we were working not just in hospitals and physician practices, but a lot of rural hospitals, but also home care, long-term care, and EMS providers. And I think, you'll see in each RIO some slight differences in sort of where they initially stand up participation. I think your experience is a little different there, Steve, correct?
Yeah, it is. I mean, not dramatically, but we did focus initially on the urban hospitals in the primarily in the Erie County core, which is the most populous county that we serve. And so, the primary hospital systems that are here, and the practices reaching out to the primary care practices in that county. Now we've since, and I would say the last 12 months, much greater push on the rural hospitals, and have had some success getting them up and running and into the process of capturing consent, and now focusing on the practices in those areas to take advantage of the fact that that consent is captured in those rural hospitals.
So when we look at our regional consent approach, we are using what we call a RIO per provider or per covered entity consent form. We also have a level 1 payer consent form. The state created a series of different consent forms, and I think Steve is usually using yet a slightly different one called a list-based form. But we've got a per provider, per covered entity consent form. We opted not to use the list-based form because we just couldn't figure out how to operationalize it, and it was a little challenging for our perspective to do that. And the patient communications looked a little trickier, but Steve and his community have been able to do that, so he can probably talk to how that worked. We then provided a series of support materials to assist the consent process, and we really work with each practice to find the ways that work best with them, but we also share best practices across care settings. We allow, and I think this is where we come back to trying to keep it simple, we allow the endpoints to set consent really easily and access a rich source of information immediately, and I think this is sort of one of the key things that people need to think about when they're thinking about opt-in. I mean, opt-in sort of has a lot of semantic vagueness to it. So our model is one where in New York we sort of talk about it as a consent to view versus a consent to load. So there's information available to physicians once they get a consent signed by a patient. And I think that is sort of been critical for our adoption rates with physicians, because to have the communication with a patient about consent and then not to have actually any clinical value for that conversation and exchange would really sort of dampen support for services. We do provide technical support for consent from the hospitals, and again, this whole patient engagement and communications area has been really key for us when we think about how to facilitate consent.
Yeah, this area is one of the areas where we do differ with Rochester, and actually I think most of the other New York State RIOs. Of course, we're opt-in as a base model, but we do use just one form that is, it's a level 1 form and does include the payers as part of the consent. Our consent is a RIO-wide consent as opposed to work group by work group. What that means is that a patient, when they sign a consent form, say at their primary care physician's office, they are granting consent to all current participants in the RIO as of the date they sign the form. So the idea here is that a patient would only be presented with one form, although they've always got the option to modify the consent status, but they would only need to sign one consent form, and that would apply to all the current providers or participants in the RIO as of the date that they sign the form. Ted referred to this as the list-based form. The state did offer that as an option, and the way we manage the list, because frankly that list is very dynamic, we have a website that contains the list of current providers and work groups, basically the entities to which the patient is consenting, that gets updated every day about 4 p.m. From the previous day's activity. And we also provide a service where any patient can call us and request a list, a hard copy, and we will package that up and deliver that to them by whatever method they prefer. So the point is that at the point that the patient is signing the consent form, they have ready access to the list of participants that they are consenting to. We do offer a number of consent options for the patient. There is the blanket yes, which is basically, again, you're saying yes to all current participants in the RIO. You have the ability to cherry pick as a patient. I can say yes to all participants except, and then list the number, a set of participants that you want to exclude from that right. You also have the ability to say no, except in an emergency. So if I happen to show up in an emergency room and perhaps unconscious or for other reasons unable to provide informed consent, the emergency room can break the glass in essence and gain access even though I had not given consent previously. And then lastly, the patient has the option to say no, under no circumstances will my information be accessible. We refer to that as the hell no option. Basically, it locks down the access and no one can get access to it through the RIO. points about the endpoints, granting consent or capturing that consent, having that done at the practice. I would agree with Ted's points about that being key, because that gives them control, but also gives them ready access at the point of care and at the point of capture to the information that is available in the RIO. From the RIO's perspective, there are really three things that drive it, I think, and one is you've got to have data that is relevant to the delivery of care. So having a high percentage of the needed data available through the RIO is key. Having adoption and use by the practice community and actually incorporating that into their workflows, their clinical workflows, is key. And then lastly, the patient's role in granting consent is the other key. If you don't have all three of those things, you're hobbling along. And so that's where patient engagement obviously is very important, as Ted has pointed out, and then working with the practices to get them to recognize the value or the potential value and get them to adopt use in a clinical workflow.
So related to that patient engagement, on this next slide you'll sort of see some of the steps we took to get out to our patients, consumers. The medical society was really concerned about having a series of uncompensated conversations with patients and having to bring all the patients up to speed on what a health information exchange was and why it was useful for them. So we did all household mailings, we had movie theater advertising, we had radio and print spots. We also created an article in Space Bank with our communications group that's got PR professionals from all our organizations. And that has been really useful in sort of letting hospitals, we have some 15 hospitals and all the regional reference labs and radiology practices. They can include articles about the RIO in their newsletters. The health plans have included articles in the newsletters. And the PR firm has also done a good job helping rural hospitals and regional facilities get local coverage. So again, it's all part of a way to try and educate patients so that, in fact, when they show up in a physician's office or a treatment setting, that they don't have to have a huge conversation about why they're being asked to sign this consent form. And what we're actually saying now is that in a lot of times patients, if we've got a practice that's not either participating with us or hasn't mentioned the consent form, they will ask for where it is and ask to have it so that they can sign off on it.
Yeah, we started an active patient outreach program a little over a year ago, actually first quarter of last year, with radio and billboards and related marketing to get the name out there. We've also been pretty active in patient-centered health fairs and related opportunities to get in front of patient groups or just get the name out in front of patients. And we found, and I think Ted was saying this as well, that at this point it's as likely as not that a patient will at least recognize the name Healthy Link and kind of associate it with the delivery of better health care. And so they sort of get past that sort of name recognition barrier. They at least recognize our logo and the name, and then with a little explanation, it's sort of an aha. Oh yeah, I remember. I saw an ad, or I heard an ad, or talked to someone at a health fair, and they'll recognize it. So it helps drop the whatever sort of resistance there might be in the individual to grant consent or be a part of the process.
So moving on, let's see here. Support services, just a display of some of the things that we provide to practices to kind of move along the process when a patient does show up in the office. We've got trifolds, Q&As, the consent form, of course, the counter cards, clipboards, stickers. I mean, we've got little stickers where if they're still using a paper EHR, that they can put a chart sticker on there that lets them know that they've captured consent already and they don't need to ask. We've got practice scripts and guidelines. We do support the scanning of their consent forms if they want us to. Otherwise, they can hold on to those consent forms. And as part of our audits, we can just look and see whether we're keeping their consent forms for them or they are. So if we ever need to pull one, we know where to go to. Additionally, we have our consumer and provider websites, and actually we now have a patient portal that lets them set consent as well.
I think the only thing I would add there, on these materials that you've listed here, Ted, are very similar to some of the materials that we've provided as well. From a consent processing standpoint, though, with our model being a RIO-wide model, we do require that all the consent forms be forwarded to us, and we do the archiving of those, and we audit and validate all the forms that come in to make sure that they are in fact valid forms, and perform a variety of audits on those forms, and use that information that we get through that process to understand perhaps where we need to do some further training or outreach to practices to help them deliver the message more clearly or more accurately, and to make sure they're capturing the consent status accurately. Real premium on that, given the kind of model we've got, because if they're not doing that well, the patient's consent may not be accurately reflected, and someone in another practice may have access to information that the patient didn't intend to have happen. So we do scan. We've created forms that are machine readable. We have about a third of our practices at this point sending those kinds of forms to us electronically, so it's pretty much all electronic. We scan the forms. We have software that validates that it's a valid form, checks the status of the consent that was checked, and validates that against what's in the system. So it's a bit more intense, and our operating costs are obviously going to be a bit higher as a result of that. But we felt that our privacy committee felt it was very important that if we're going to have a RIO-wide consent, that we centralize the management of the consent forms, and we become, in essence, the single point of truth for the consent status as checked.
So when we look at some of the practice findings, we heard early on that the practices were concerned by the effort that would be involved in setting consent. Often we heard that it would be difficult to sort of explain the concept of consent to load as opposed to consent to view. Practices were concerned by what the patient's reactions might be. So a lot of these things came up way, I think, 2006, 2007 when we just started up. Some common practice questions have always been sort of when should we provide the consent form? Should we do this with every patient? And what we've found in those practices that have sort of streamlined it the most is that, yes, in fact, if it's part of the standard workflow, it works really well, though there are some practices that still just take a as-needed approach, and it works for them. Then some have asked if they can, mail the consent forms in advance and just bring them with them, and certainly they can. I think our findings have been that the implementation was a lot easier than expected. Practices have found that patients are really quite receptive to health information exchange, and when you look at some of our audit requests that haven't been really related on who's looked at my information, but how come no one is sometimes, which is sort of curious. I think the patient's relationship with the practice is key. Obviously, they trust their physicians. Most practices have not pushed back. I think one of the things to keep in mind is, depending upon the type of practice, we do have a lot of practices where it's sort of a closed practice. There's not a lot of new patients. They have a fairly straightforward referral network. They're not using the query portal that much. They're getting results delivered right into them. And so depending upon how the practice uses our tools, they may have this consent status approach, and they may not. So we haven't gotten a lot of pushback. There are still a few practices that would prefer not to get consent, and it's just one of those things that unless they see value in it, they certainly don't have to. I think what we've been very fortunate with in our community is that the practice has been very helpful in us keeping our regional master patient index updated. So when they, and that's sort of a key concept, that these HIEs live or die on being able to match to the right patient, and you're getting information, in our case, from lots of different entities. So keeping that updated and clean and accurate is key. And so we're actually, the practice has been very helpful in us, highlighting when there's a patient discrepancy on a patient index.
Yeah, I would just reemphasize that point about the CPI and having it be clean. It's really a community resource, and it's quite useful both ways. The other thing I would just add regarding the practices and where that trust is, it really, the patient trust really is primarily at, we found anyway, with the primary care physician and in the hospital settings. Our rate of capture of consents tends to be higher in those two settings. We've tried other avenues. For instance, at the health fairs, we always provide people the opportunity to grant consent. It's pretty rare that someone actually does in that setting. We've tried other avenues, considered working with the Red Cross or other entities, and really those other avenues are fine for building name recognition, but for the actual capture of consent, it's that trust relationship with your doctor, and again, primarily a primary care physician doctor, that yields the highest rate of consent.
Our hospital findings are different. I think you'll see as you move forward that some hospitals can implement this kind of consent process easier than others, and it really depends upon where they're using the HIE services. And we've spent a good bit of time working through most all of our hospitals, really trying to define and analyze where the most value is and how the workflows work the best. The use cases really do drive this, so emergency departments, cancer centers, radiology services, and own practices. The registration environment really does impact the consent process, so if the hospital doesn't have a centralized registration system, that can cause some issues because there's really no internal way to then track that consent status that they've gotten within their own system. Where the hospitals have been able to establish a flag in their own clinical information system, it's been a key step for us, such that now 1/3 of our hospitals actually provide, using that type of flag, an automatic consent integration with our RIO so that their consent status flows directly into us, and we're always in sync, and it's made those workflows really smooth.
Yeah, I'm not sure I'd add anything to that, Ted. I think your findings there and experience is the same as ours.
So moving forward, our metrics will be a little different, but I'll just go through what we've been doing in Rochester. As of May 1st, we've consented 448,000 unique patients. There's an additional 182,000 consents where we're up in the 600,000 range here, where patients have consented to more than one provider, keeping in mind that we're sort of a per practice or per provider consent model. Consent rates tend to consistently run around 98% positive opt-in. We're seeing anywhere from 27,000 to 40,000, from 20 to 40,000 new patients consenting each month. Keeping in mind, again, that these consents really cover access to some 400 organizations. We're getting around 20,000 patient queries each month. It goes up and down. We did an interesting research project here with a consortium from Cornell Weill, University of Rochester, University of Albany, University of Buffalo. This is not the high-tech, the federal high-tech. This high-tech is a state consortium of academic institutions researching the value of HIE and HIT in New York State. I think it stands for Health Information Technology Evaluation Consortium. So we did a consumer research project, and that research project really showed a very high support for HIE, remarkably high support for PHR as well, a lot less support for viewing their information without consent, and also, and I think this sort of informed some of Buffalo's approach, also very high support for emergency access without consent.
So our numbers, as Ted noted, are a little different, and our model, of course, is different. Ours being Rio-wide. We've got about 220,000 unique patients that have granted consent across the Rio. Our positive rate is about 95.5%, and the no's basically break down pretty evenly between the no except an emergency and no even in an emergency. We're getting around 15,000 consents a month, and most of that is from practices and specialty specialists. We've only got a couple of hospitals currently capturing consent. We've got a couple more staged that, when they go live, should just about double that rate we're expecting. Yeah, we also participated in that high-tech research. I only just saw the results of that last week, so I don't have the numbers, but I kind of walked away from that with an impression, I think, consistent with what Ted was seeing there in Rochester with their study and their, the patients' attitudes towards the Rios and access to the information. Okay.
So this next slide is just really quick, a snapshot of our consent trends. There's two trend lines. One is for unique patients. The other one is for cumulative consents. So the green is total number of consents, and that's over on the left side. So we're up to the 600,000. The cumulative patients you'll see is really the pink trend line. So there we are over the 400,000 mark. And you can kind of see the monthly numbers. Those are the histogram bars of consent numbers on a monthly basis. So not much news there. It's just really how we track consent. But we've consented about a third of our entire medical service area population thus far.
Yeah, our numbers from a trend from a trend line perspective, we've been seeing an acceleration. The rate of growth we were seeing last summer, rates in the 6,000 to 8,000 a month. We're currently, as I said, running about 15, and we're again expecting that to further increase as we get the hospitals to sign up. But we're expecting at some point, perhaps in a year or less, that we would see the rate of consents drop off, because as we get a higher percentage of the population to consent, the odds that a patient coming into a care setting has already consented go up, and that's where one of the ways in which the Rio-wide consent yields some long-term value. At some point there'd be less and less need to ask patients for consent.
So really briefly, we sort of go into some of the things we've been doing with consumer and patient engagement electronically in our patient portal. Clearly, consumer concerns are really always minimized when they have a sense of control, and we keep seeing that in conversations with them and in focus groups. So we spent a little bit of time. Again, this was really initiated way back when there was some physician concern that setting consents would be problematic in the physician setting, and how could we automate the process. So we've created a portal where they can manage their consent. The consent management alone, I don't know how much consumer value it has. I mean, clearly we're having patients already that are starting to set consent online, but that's sort of one part of our patient connectivity strategy where they can conduct a couple different transactions. I think the most popular transaction actually, and this has just really been gone up since April, is requesting audits online electronically. Also scan and attach an advanced directive, and then starting in the June-July timeframe, we'll be providing bidirectional PHR connectivity services.
Yeah, we don't have a patient portal up yet. We are just starting that project, and we expect sometime mid-year to have it up. It is primarily in support of a couple of the grants that we've got, one being Beacon, and it will be very focused on the diabetic population and getting them engaged in their care, so we're looking to use the portal for that population. and the other is the HEAL 10 grant, which is a patient-centered medical home effort, and so we're bringing up a portal in support of that as well. But we don't have any results to report on that. Our expectation is that the primary use and value will be in the delivery of clinical results to the patients so that they can view those results directly.
Well, once you put that online, I can tell you that your requests for audits will go up. You know, we've seen probably a tenfold increase in the number of audit requests through our portal than what we were getting online. So it's encouraging. Patients really do want to know what's going on. Let's see where we are here in terms of moving forward.
I think that was the last slide.
Well, then I don't need to move forward.
I think we can have questions. Sheldon Taubman is on and has raised his hand, but unfortunately, Sheldon, you haven't input your audio pin, so I can't unmute you for you to ask your question. You can either do that or you can enter it into the question panel. But in the meantime, I'm going to take a prerogative of the organizer and say, this is just phenomenal. I'm really glad that we could share this with Connecticut. You've built a very patient-centered process and system here, and that feeds into patient-centered medical homes and having people take control of their own healthcare. A lot of the initiatives that we all support that are moving forward in healthcare, and I think that's really important in it. But it's very gratifying to see that that's been that patients really respond to that, and they see it as a helpful, positive innovation in your evaluation. And I love the comment you made that patients are now asking for their consent form when they don't get it. I think that's fantastic. That's my dream as a consumer advocate. One of you, when we were interviewing you, and I apologize, I can't remember which one, mentioned that you had been concerned when this first went up because one of the TV stations was going to do man-on-the-street interviews, and you were worried that, you know, you'd get
that was
concerned. And maybe you could just share your experience with that.
Yeah, our local news media outlet went out and canvassed the community, and we all sort of sat back with bated breath, and they found some seniors out in a suburb just, I think, west of us a little bit, and I couldn't have paid them to be more lucid about HIE services. They were sort of saying, well, wait, if my physician's on vacation and I showed up in an emergency room, why wouldn't I want those doctors to know my medical condition? That's common sense. And that was our sort of first entree out into the consumer space and the 7 o'clock news, and it worked really well for us.
That's great. I also wanted to just confirm with you that both of you upload information to the portal, to the exchange, but it's consent to get access to it, and that's unlike Massachusetts and Rhode Island, where information isn't even released into the exchange until people consent. Have I got that right?
Yeah. Through the New York State privacy process with lots of lawyers in the rooms, everyone sort of looked at the sort of business associate agreements that vendors sign with hospitals now and radiology practices, and really mapped out what's already going on, which is clinical data moves from a hospital, lab, or radiology practice to a variety of settings, to outsourced or other vendors that are performing services on their behalf. And patients really don't consent to that process. It's covered under their business associate agreement, and RIOs are in much the same way, providing a service for their stakeholders. The key for us, of course, from a patient privacy perspective was not where the physical data lived, but who could see it and the controls of that. So you're absolutely right that the New York model is that we can establish the interfaces, the data can get sort of pre-staged or connected, but care providers need consent to view it.
Okay. A question around whether your consent form, you both talked about, I believe the answer to this is that you have separate consent forms. Did you ever look at integrating with the HIPAA form?
There were a lot of state discussions through 2006, 2007, and it was seen to be sort of unique enough that we really wanted to have patients aware of what an HIE was. It certainly has HIPAA language in it, but the state really wanted to call out and, in the world of really informed consent, make it clear that this was an HIE consent. There was a different sort of information model now.
Great. Steve, I don't know if you want to answer, add anything?
Not to that. I think, I mean, Ted predates me on some of those conversations at the state level on regarding the HIPAA form. I know it's come up. I've had, we've had to field questions from practices related to that. But I think, as Ted noted, there's enough uniqueness, at least currently, relative to HIEs that it sounds like the state was, the decision was made to have it as a separate form, and we operationalize that as we must.
Well, I think that just points to the patient-centeredness of this, is that you don't just want the signature, you actually want them to really consent. I think that's wonderful. Another question, how do you, I think Steve, you said this, how do you audit the forms?
Well, it's a bit more manual, or at least historically was. Basically we had people eyeball each form to validate that it was a, was a valid form, that there was a signature present in the right spot, there were dates, that they checked only one box and didn't check all the boxes, and just make sure it was a valid form. And then we also did and do 100% audit of all the no consents. So if we get a form in where the patient has selected one of the no options, we do a 100% audit in the system of those forms to make sure that it's accurately reflected in the system. We do a number of other sampling audits, to confirm that consent forms are being accurately and correctly recorded in the system. And as we deploy the scanning technology and the OCR technology, we'll be able to automate those audits to a much greater extent, so that when we get the form in, we're using software basically to do those audits against what's reflected in the system.
Great. Well, it looks like, I'm sorry?
Sorry, I was just going to say we do a variety of other spot audits around access, and I think, Ted, you do as well. Things like same name access, we'll identify any access where a patient was accessing a user was accessing a patient with the same last name, and other audits of that sort to just monitor usage to make sure it's appropriate.
Great. I think that's the end of the questions. Is there anything else either one of you would like to say?
No, I think just following up on Steve's piece too, I think providing the transparency to consumers about who has looked at their information is also a great insurer at some level. I mean, it's not 100%, but it certainly helps in our training of physician practices and others when we sort of let them know that we have very detailed audit logs, more detailed than many hospital portals, and those audit logs end up getting made available to consumers on request. So while we do sample audits of our consent forms, I think the consumers are sitting back there too and able to watch and make sure that their information isn't appropriately used or viewed.
We almost look for excuses to send a practice an audit result, just so that it drives home that point about we're literally able to track every click, and we want the practices to know, just to sort of sharpen the focus, that the usage has to be appropriate, and they're responsible for monitoring that is so. And so by making it clear to them that we've got these audits going on and we're sharing that with them and expect them to follow up on those things, it helps sharpen, I think, the message they deliver to their staff, and I think it helps sharpen the message they deliver to the patient.
Well, this has been incredibly helpful. I want to thank you both very, very much and let everyone know that the slides as well as the video of this will be up on our website very soon. Ted and Steve, thank you very, very much.
Thank you.
Pleasure. Thank you.
Thanks.
Bye-bye.